Dear colleagues, my name is Arya Sharma. I'm professor of medicine at the University of Alberta. And it's a pleasure for me to be talking to you today about the new Canadian Obesity Clinical Practice Guidelines, which were released last year. So let me just bring up my presentation for you here. Okay, here we go. So the 2020 Obesity Clinical Practice Guidelines was a joint project between Obesity Canada and the Canadian Association for Bariatric Physicians and Surgeons. It was published last year in September in the Canadian Medical Association Journal, which is the most prestigious Canadian journal. This journal gets mailed to every single physician practicing in Canada. And it turns out that despite the entire COVID problem, this was actually the #1 downloaded articles in CMAJ, which really shows us that physicians have a lot of interest in the issue of obesity, as they should. Now, what I want to cover in the next few minutes is I want to talk very briefly about the rational scope and the methodology used for these guidelines. I then want to highlight some of the key previous changes from previous guidelines, because there are some important points here. And then I just want to very briefly touch on the expanding role that I see for obesity medicine in general. Now, in terms of rational scope and methodology, the last time we had guidelines in Canada was back in 2007. So that was 14 years ago. And since then, a lot of things have happened. For one, we've had the Canadian Medical Association declare obesity as a chronic disease. That was back in 2015. We have learned a lot about the impact of bias, stigma, and weight-based discrimination on our patients and access to care. And I'll talk about that very briefly. We've had an enormous expansion in our understanding of the science of obesity. We understand now much better how the body regulates its body weight. We understand a lot of the subcortical processes that are involved here. And we have certainly learned a lot about the biology of how the body protects itself against weight loss, which of course is relevant when we are trying to get our patients to lose weight in the long term. There have also been a number of advances in obesity treatments and therapies, many of which I'm sure you'll hear from or hear about throughout this meeting. And I think that we have also come to recognize that in obesity, like in many other diseases, we have to take a patient-centered care, and we have to look at outcomes beyond simply weight loss. Now, given that obesity is such a common condition affecting so many millions and millions of people, this is not a condition that can just be seen by a handful of specialists. So we have to think about the fact that this is a condition that will primarily have to be treated by the family doctor. And that is also why the family doctors or primary healthcare professionals are the target audience for these guidelines. This is not a guideline written for specialists. This is a guideline written to be practical so that every family doctor, every practicing physician who sees patients on a daily basis for whatever purpose will feel more comfortable in addressing obesity and approaching obesity. So the guideline is really intended to improve the standard of and access of care to all individuals living with obesity. Now, in terms of the key changes from previous guidelines, perhaps the most important change is the definition of obesity itself. As you all know, that in the past, we have always used a body mass index-based definition. The problem with body mass index, as you all know, is that it is calculated simply from height and weight, which means it is really a measure of size. It's not a measure of health. And we know that, across various ethnic populations, the relationship between BMI and health can be very different. For example, in South Asians versus Caucasians, there's a lot of difference there. But we also know that even within one ethnic community, there can be tremendous differences in the relationship between body mass index and the presence of any health issues. So, for example, you can have two people who both have BMI 35, and one of them has all kinds of health issues, fatty livers and whatnot. And the other patient or the other person at BMI 35 might actually have very few health issues or no health issues. And so we have to move beyond just a body mass index centric view of obesity. So what we've done in these new guidelines for the first time in any guideline, we have defined obesity as a prevalent, complex, progressive, relapsing chronic disease that is characterized by abnormal and excess body fat that impairs health. And the key word here is impairs health. If you do not have a health impairment that is attributable to excess weight, then you don't have obesity. Obviously, as you go to higher and higher body mass indexes, you're always going to find that people have more and more complications. But the defining characteristic of obesity is not your size, it's not your weight, it's not the number on the scale. The defining characteristic of obesity is a health impairment that is attributable to excess body fat. This doesn't mean we should forget about body mass index or waist circumference. Of course, they are useful measures because they can be used as screening tools, but they should not be used simply for the diagnosis of obesity. This has to be based rather on the presence of functional, medical, or psychosocial impairments, which are related to the presence of abnormal or excess body fat. And that means that you are going to need a clinical exam, a visit to your doctor, doing appropriate tests, to determine whether or not someone has obesity. It is not something you can do by yourself, step on the scale and decide. Now, having said that, of course, we have to remember we are talking about a chronic disease. And this means for us that obesity management should be based on the evidence-based methods of managing chronic disease, which we are all familiar with, but because we apply the same rules for chronic disease management to every other chronic disease. When you think about your patients with diabetes, your patients with heart disease, your patients with, with chronic obstructive lung disease, there are always principles of chronic disease management that we understand and we know, including patient education, self-management, regular follow-ups, self-monitoring, and all of the other, factors or techniques that we know work so well for chronic disease. We have to apply them to obesity, and we have to move beyond simply telling patients to eat less and move more, because we have a lot of data now, including data from randomized controlled trials, showing that for most patients, this approach is not effective. In fact, it can actually be detrimental to patients' health, because simply by eating and moving more, even if you manage to lose weight, the long-term success is actually quite limited. And so, we state very clearly that people who are living with obesity should have access to evidence-informed interventions. And these, of course, have to include medical nutrition therapy, physical activity, psychological interventions, pharmacotherapy, and of course, also surgery. So having said all of that, what we present in the guidelines is a 5-step approach to obesity management, which many of you might have heard of, called the 5A step approach. And the first step here is the ask. And here we have to recognize that obesity as a chronic disease carries a lot of bias, carries a lot of stigma. And therefore, it is very important that as health professionals, we acknowledge the presence of bias, and we understand that this is a sensitive issue for many patients. And therefore, it is very helpful and perhaps advisable to always ask patients for permission before we offer any advice on obesity or on their weight. And when we do so, we need to do this in a very unbiased manner. We have to remember that weight bias is very, very common. People living with obesity, they face substantial weight bias and stigma, and this has a direct impact on their health and well-being, as well as on their access to care. So in the guidelines, we specifically recommend that all healthcare providers should assess their own beliefs and attitudes towards people living with obesity, and think about how your attitudes, which might in many cases be negative or rather simplistic, and how these might actually influence the healthcare that you're delivering to your patient. At the same time, we should also be aware that many patients blame themselves and carry what is known as internalized weight bias, and that this presence of internalized weight bias can actually have very substantial adverse effects on their own behaviors and their own health outcomes. So we have to acknowledge and in fact, assess patients for the presence of these negative feelings that they have towards themselves. The next step is assessment step. Now, in the assessment of individuals living with obesity, we obviously have to use appropriate measurements, but the goal here is to identify the root causes and drivers of obesity, to look at the complications, and also find out and assess the barriers to obesity treatment. Now, the framework that we recommend for this is called the 4 M's framework, and the 4 M's stand for mental health, where we have to, understand that any aspect of mental health is going to have an impact on body weight, whether this is knowledge, expectation, self-image, depression, anxiety disorder, attention deficit disorder, past trauma, grief. All of these factors can very substantially promote weight gain. Sometimes they can be consequences of excess weight, and in many cases, they will be important barriers to weight management. So we have to assess mental health. We have to look for mechanical complications, so osteoarthritis, sleep apnea, etc. Because again, many of these complications, they can drive weight gain, they can be consequences of excess weight, and they can make weight management very difficult. Of course, we also have all of our metabolic problems. We have type 2 diabetes, dyslipidemia, hypertension, there's a long list of problems. And again, many of these problems can contribute to excess weight. They can be consequences of excess weight. And the presence of these conditions can make obesity management quite difficult and challenging. We should remember that very often the medications that we use for treating mental health or pain or metabolic disease can themselves be part of the problem, in that they promote weight gain or make losing weight very difficult for patients. So every assessment for obesity also has to include a review of all of the medications that patients are on. Finally, we have to always appreciate the importance of the social milieu in which patients are, the socioeconomic status, their education, their occupation, what is their access to food, disability, access to medication, access to surgery, access to other treatments. All of this information is required in order for me to complete an assessment of obesity and in order to come up with a treatment plan. In the next step, it's important to remember that there's no single blood test or diagnostic evaluation that you have to do in every patient. Now, we recommend in the guidelines that all evaluation should be based on presenting symptoms, on the patient's risk factor profile, and of course on your clinical index of suspicion. Now, obviously for most patients, this is going to include screening for metabolic syndrome with HbA1c levels, fasting blood sugars, cholesterol, lipid levels, etc. But there is not one test that is compulsory that you have to do in every patient. You have to use your clinical judgment in deciding which tests you want to do for a patient based on the symptoms that they're presenting, their age, their risk factors, etc. Obviously, patients at high risk of fatty liver syndrome, which includes everybody who's got type 2 diabetes, they should probably be screened with an ALT level and perhaps even an ultrasound. Now, having said that, as many of you know, and as I've already mentioned, the body mass index itself is not a very good predictor of outcome. And so, as many of you might have heard by now, we have the Edmonton Obesity Staging System, where we classify patients based on the presence of comorbidities. And in population studies, we have shown that this is a much better predictor of long-term survival or all-cause mortality when compared to body mass index. And our clinical decisions and should really be based on more than just BMI. And so we strongly believe and recommend in the guidelines that we use the Edmonton Obesity Staging System, which now has a lot of evidence behind it, to support clinical decision-making in terms of which patient needs treatment and what treatment should be applied. So once you've done the assessment, we come to step 3, which is now giving the advice to the patient. Here we discuss the different treatment options. We talk about whatever option should be there. Obviously, we want to talk about medical nutrition therapy and physical activity, but we have to remember that for most patients, you're also going to need psychological interventions, or probably pharmacological interventions if the patient has access, and then of course bariatric surgery. And we should not look at these treatments as being, first do one, then do the next, then do the other one, but we have to look at them as complementary. These can be combined. You can have a patient who changes their diet, does physical activity, has psychological intervention, takes a medication, and in spite of everything might still need bariatric surgery. So we have to look at combining all of these treatments as appropriate, always keeping in mind that our goal here is not to maximize weight loss, but rather to get the maximum improvement in health. The step 4 is then to agree with your patient on the treatment pathway, and ultimately, because this is a chronic disease, you have to assist your patient on the pathway. This is a lifelong pathway. We don't have a cure for obesity, but it can be managed, but this requires long-term management. So having said that, the guidelines point out that there's an increasing scope of obesity medicine. The guidelines are very comprehensive. There's 270 printed pages. There are 80 evidence-based recommendations touching on many, many aspects of obesity management, including pregnancies and menopause and and mental health and pre-surgical and post-surgical management of patients. So, I recommend that you take the time, if you're interested in the topic, and download the guidelines, or at least look at the guidelines. They are freely available at Obesity Canada. And if you just Google Obesity Guidelines Canada, I'm sure you will find the page, and I hope that you will take the time to review these guidelines. So thank you very much for your attention. I'm sorry I cannot be there with you in India right now. but hopefully I will be able to travel to India soon. And I hope you have a great rest of the conference. So thank you again for your attention.